Okay, so now we're going to talk about the primary assessment. First thing is our general impression. We've all been through this before. We're going through it again. Sick, not sick. Bad, good. Pretty simple. What is your general impression? Based on your scene and your patient presentation, are they sick or not sick? Responsiveness. AVPU. Alert. Verbal. Painful. Unresponsive. AVPU. Which one works? Do they respond to you when you walk up? Do they turn their head and look? Or do they make attempts? Or do they talk to you if you approach? Hi, my name is Roman. I'll be your paramedic today. How can I help you? Oh, hey, my name is Joe. They're alert. Or they could say something completely irrelevant or inappropriate. Doesn't matter. They are alert. This has nothing to do with level of consciousness, just responsiveness. If you walk up and they don't make any they're not making contact with you, they're not responding to you, but you ask them something and they respond, they are now verbal. They're not alert, but they are verbal. Do you do a sternal rub or some other painful response to get a response out of them? If they respond to it, then they are a painful response. If they do not respond to anything, they are unresponsive. Pretty down and dirty. We're going to go over this in greater depth later. Just touching on it. Now we're going to assess airway. Breathing. And circulation. Is their airway open? If they turn and talk to you, you know that their airway is open and they are breathing because they are speaking to you. And you can assume that there is circulation involved in that. We are going to look, listen, and feel. Our basic CPR approach. We are going to kneel down next to this person if they are unresponsive. We are going to look, listen, and feel. Do we listen? Do we hear breathing? Do we see chest rise and fall? Do we need to open the airway? If we open the airway, do they start breathing? Assess life threats. And treat them immediately. Assess life threats, treat immediately. Do you notice a large pool of blood and arterial bleeding? We need to tourniquet it. Is it a large pool of blood, but it's more oozy, more venous blood? If it's a large pool of blood and it's there, I'm plugging holes. Then we're going to work on airway. Then we're going to work on breathing. We need to plug the hole to preserve oxygen carrying capability. And then transport decision. Stay and play. Or load and go. Do we have time to continue on with an assessment and treatments, or do we need to load and go? Is there injury? Is that life threat still there that we need to get and go and we continue en route, or can we stay and stabilize a little further and make it, and do we have the time? We must record, take and record patient history, pertinent medical history. We don't need to know that they had their tonsils and adenoids taken out at 3 years old, unless it's pertinent to the injury at the time or the illness at the time. We need to continuously monitor the patient. Continuously monitor the patient. We need to make sure that they don't deteriorate. And we need to recognize it when it's happening. Provide additional care as needed. We need to keep our head about us. Okay, so they've had a bleed. We tourniqueted it. We've stopped the bleeding. Is that enough? Are we done yet? No. We need to start an IV. We need to get some fluid on board. However, we need to use caution in how much fluid we give. Can we give too much? Absolutely, we can give too much. Does the fluids we have, the isotonic fluids that we have oxygen carrying capabilities? No. So all we're doing is maintaining circulation at that point, maintaining a perfusing pressure. So, but will that IV assist the ER in getting blood and other oxygen carrying capability improvements to this patient faster? Absolutely. Will an IV in place help get medications on board faster? Yes. Will an IV facilitate faster lab results? Absolutely. An IV, now I'm just using this as an example. This is just one example of additional care as needed. IVs are very easy to justify. You know the procedures that the ERs are going to take and what they're going to do as soon as you bring a patient in. What is one of the very first things that the doctors want to know? They want to know blood tests. They want to know what a CBC is. They want to know what their, depending on the complaint, they may want to know troponins. They may want to know cardiac enzymes. They want to know kidney function. You know, they want to know all this information. And if they have to wait another 15 to 20 minutes, depending on patient condition, for the nurse to start an IV, that could be a problem. It delays treatment. An IV is the easiest procedure to justify in the field. We must be able to recognize illness or injury. So all that is great. All the primary assessment, all that's great. But if we don't recognize an illness or an injury, how good is our primary assessment going to be? How good is our sick, not sick, hurt, not hurt judgment going to be if we don't recognize that there is an illness or an injury? This is our first aspect. The first thing we looked at, this is what decides our very first patient prioritization. Go, no go. Stay and play. Load and go. Based on our first impression, our first thoughts, and our recognition of illness and injury. This is what we base our patient priority on and our transport decision. If we don't recognize there's an illness process, a disease process, or an injury process going on, we screw everything else up. We may not prioritize them properly because we don't recognize what's happening. That's why we need to be strong in pathophysiology. We have to be strong in our patient assessment skills and our visual skills and our picking up on the clues and talking to the patient and the family. They are your best sources of information. If we don't get this right, it can screw up everything else past that. We've got to be able to recognize. Now, as we move into patient management, the key in our patient management, aside from our knowledge and skills and abilities, is our knowledge of protocols. We need to know our protocols or our treatment guidelines. This is what our medical direction has decided will be our course of treatment based on our knowledge and experience, what we see is wrong with the patient. So we must follow those protocols. Ensure the proper use of equipment. And availability of personnel. So what does that mean? We need to ensure the proper use of equipment. Are we using the equipment properly? Is the Lucas properly placed to continue CPR so it frees up another set of hands for starting IVs or giving medications or placing an airway? Do we have enough people to do what we're doing to properly take care of this patient or this situation, the call in total? We need to know how many people are available, how many people are on shift that day. Are we short? Do we have a second out or reserves at home? Volunteers waiting with pagers, listening to see if we need help or if there are more calls coming in than we can handle. Is the proper equipment on scene for the proper call? The best analogy I can use for this is like fire department. Did we bring a rescue truck to a multi-story structure fire where we needed the ladder platform? Did we bring a chase car when we needed an ambulance? Or is that all we had? We had one person that was able to respond because all other resources are tied up. We need to know that every day. We need to know when it changes. And as a street level person, not in a management or supervisory position, we need to know that information as well. That way we can call for assistance and we know what assistance to call for. Medical direction. Provide instructions on how to proceed. With treatment. By way of protocols and or guidelines, and the medications that we give and when we give them, the procedures that we do and how we do them. Medical direction provides this oversight, whether it be online, offline. They grant us permission. I should qualify this with training and permission to perform procedures. and through to standard care. That falls back under training and permission to perform procedures. If there is an alternate procedure or treatment that they want you to do that may not be in standing orders, they need to give that to you online. They need to ensure that you are familiar enough and that you have been trained and they have given you permission to do that procedure or that treatment. Medical direction is the only one that can do that. You cannot do that on your own. It is up to you to verify the directions that are being given, the medications, the dosages, and the procedures. You must verify that and perform it as instructed. Otherwise, you are practicing medicine and you are making decisions outside of your scope. These are all things to keep in mind. This is what medical direction does for us in a nutshell. Medical direction also oversees this program. Dr. Harold Perkins is our medical director. He approves and guides how this program proceeds with your competencies and the numbers of procedures that you must do in training before you are allowed to do them in field internship and in clinicals. He is one of the final sign-offs on your ability to test for the National Registry. There are many facets to this that medical direction takes part in. Okay, now the appropriate disposition. Okay. These are the appropriate things that happen to the patient. The disposition is what has happened to the patient, where they have been taken and the treatments they have been given. We must assure that the patient is taken to the proper facility. To appropriate facility by appropriate transportation. Okay, were they taken to a Band-Aid station, urgent care, when they should have been taken to a trauma center? Were they taken to the trauma center by ground with a 2-hour transport when they should have been taken by helicopter to the nearest trauma center? These are the things, the appropriate disposition. Were they treated and transported appropriately? Time and distance and patient condition are all key factors in this. Know what's available. Do you have... Are helicopters available in your area? Is there a helicopter? Is there a trauma center? How far? Is there fixed wing? What's the weather? What's appropriate? What's your patient condition? Finally, and above all, follow local protocol. You may have a small ER locally, but your trauma center is 4 hours away or 3 hours away, and you have a helicopter based nearby. Does it make more sense to drive that patient that needs the trauma center the 3 or 4 hours? Or does it make sense to go to the local ER, stabilize a little further, put them on a helicopter, and get them there in 45 minutes to an hour, cut that time in half? Is there a fixed wing available? Also, we got to take into account the weather. If it's not good for a fixed wing or a helicopter to fly, chances are you can drive it, but are you going to drive them from the scene? No. You're going to take them to the nearest appropriate facility per your protocols, which is most likely your little ER. They are going to be seen by a physician, consulted, and transported to the nearest appropriate facility. They can get more care, a little bit more care than we can give. They can get imaging, CT scans, x-rays, further treatment above and beyond our local protocols, and then taken to the appropriate facility. If you are in a major urban area, selecting the appropriate facility, whoops, that was ugly. The appropriate facility is your responsibility. So you've got, you know that your patient needs a level 1 trauma center, and the level 1 trauma center is 30 minutes away. And there is a level 3 that is 10 minutes away. Are you going to delay the transport to take them to the level 3 and turn them over to that hospital and that ER, or are you just going to travel, that's all within your response area, or are you going to travel to the level 1 because that's where they need to be? The appropriate facility is your responsibility. It is your responsibility to know what the hospitals offer. You must know what your hospital is capable of. Is your hospital a stroke center? Is your hospital a cardiac center? Do they have a cath lab? Do they have, are they capable of doing open heart surgery? That's a little deep, but know the capabilities. Are they a heart center? Are they a level 1, level 2, or level 3 trauma center? Are they a level 4 trauma center? They are based, or they are categorized based on ability or level of care provided. So in NICUs, NBICUs, not that many of us will have much to do with an NBICU, but you may have a transport. Levels 4, 3, 2, 1. This is the least treatment ability to the highest level. Trauma centers, which is what we'll have most interaction with is the exact opposite. Level 1, 2, 3, 4. Got highest, level of abilities to the least. Level 1 is the highest, level 2 is the next, level 3 is the below that, and 4 is the least. And then you have your Now that's not to say that a hospital does not have the ability to treat a trauma patient just because they are not a leveled trauma center. They may have the capabilities, they may have the imaging, they may have everything they need. They have just not gone through the process to become a state certified trauma center for whatever reason. Or they may have a higher level of care or a higher ability of care than a level 3, but less than a level 2. They may not have the doctor coverage that they require for a level 2. They may not have the, based on the equipment, they may not have the imaging capabilities required for a level 1. These are things that, nitpicky little things that you may or may not need to know. And you may only have one hospital in your area that makes the decision easy, because that's where you're going to go with everybody. But you need to know where in the state these are. Wichita has 2 level 1 trauma centers. Kansas City, Kansas, Kansas has 1 level 1 trauma center. There is, I believe Hayes is a level 3 trauma center. Topeka has 2 level 2 trauma centers. Satanta, Kansas, south of Garden City, south and west of Garden City, just a little bit, has a 2-bed ER and is a level 4 trauma center. Know your facilities. The book refers to us as somewhat of a gatekeeper of the healthcare system, which is in essence fairly true. For much of the population, we are where they enter the healthcare system. They don't have a regular doctor. They don't have a clinic that they go to on a regular basis, whether it be because they can't afford it or they've never needed it, they didn't have insurance. Name the reason, they just didn't go. They wanted to deny that they were in any kind of health crisis or anything until it's too late. And then they call the ambulance, and that's where we come in. It is up to us to know and to accurately judge the patient's condition and make sure that we are taking them to a facility with the proper abilities to take care of what their problem is. Again, many of us are in small areas that do not have access to these bigger hospitals, and they may not even be close enough that we can take our patient to these directly. However, through transfer, through interfacility transport, again, this is something that we need to know where we're going, and we need to prepare appropriately for that. Part of taking care of our patient is ensuring that they have received the care that they need, not only from us, but from the hospital, and then continuing that care in the back of the ambulance on the way from one ER or one healthcare facility to another. Our care doesn't stop. We're not just sitting there monitoring them during that trip. We need to ensure that we are taking care of that patient, and anything that changes, we are able to react and adjust to it and treat them appropriately. So that's why it's important to know what is in your area. What are your hospitals? Now, I mentioned a few hospitals, and that's the last time I looked at the list of level 1 or facilities as far as trauma centers. I have not looked at that list in the last couple of years, and it may have changed. We'll discuss that later. It's everybody's area here is a little bit different from everybody else's. Northeast is going to be different than North Central, and down here in the Southwest, where everybody's from, each place has its own unique capabilities and distances to upper or higher level of care. Okay, so now we're going to talk about our levels. Now these are trauma centers because these are what we're going to deal with more than anything is our trauma centers. So a level 1 trauma center is usually a regional resource trauma center, tertiary care facility for trauma care system, and is usually generally a university-based teaching hospital. So for example, Kansas City is University of Kansas Med School Hospital is the level 1 trauma center. Ultimately, all patients who require the resources of the level 1 center should have access to it. Of course, well, we're here in the southwest corner of the state, and it's a 6-hour drive to Kansas City. I've made it several times for us. It is a 1.5 to 2-hour flight by fixed wing, which helicopters will not make it to Kansas City. Not from here, anyway. So getting to a level 1 trauma center from Garden City, Kansas is a pretty good feat to Kansas City. That being said, we have 2 level 2 trauma centers in Wichita, Kansas. And they are by ground 3.5 to 4 hours away, depending on weather, road conditions, and whatnot. Or 30 to 45 minutes to 45 minutes to an hour and 15 minutes by air, fixed wing and or helicopter. The benefit of helicopter is they can land right at the hospital, whereas fixed wing has to go to the airport and be transported in by ambulance. So if we need to get to a level 1 trauma center from out here, it is possible, but we have to go to our local ER first for stabilization. Level 1 trauma center requires a large number of personnel and adequate facility for patient care, education, and research. Most level 1 trauma centers are university-based teaching hospitals. Other hospitals willing to commit these resources, however, may meet the criteria of level 1 recognition. There is an application process, and it's all about what you have in your abilities to provide to patients.